So we're going to start off today by talking about the objectives, just general overview of what we're going to talk about today. So to put simply, we're going to explore our reasoning for engaging in directed study process, as well as the background for each of our directed studies process E's or I's, critical theoretical perspectives and application to our specific areas of interest, and to discuss the impact of critical theoretical perspectives towards practice policy, including nursing research.
So just before I kind of outline how we're going to approach this, I wanted to just take a moment to talk about why this collaborative, how this kind of came about, and how this sort of presentation came to be. We actually, when we both started our summer terms, we found out that both of us were wanting to do directed studies on critical theoretical perspectives with Helen, and I think what this really provided for us was an opportunity to really have an even more richer engagement with critical perspectives beyond just what we were reading in our particular fields, and an opportunity to more formally create some dialogue between the two of us in terms of what we were doing and what we were learning. So how we're going to structure this presentation is we're going to start sort of a little bit separately and talk about each of our own journey towards these directed studies and developing these courses of sort of how did we start with engaging with critical theoretical perspectives. We're going to then come together and talk about what these perspectives kind of in common for us draw our attention to or draw our attention away from, and then separate back out and talk about application in two very distinct areas, in my field of healthcare transition research and in Marina's field of mental health and substance use policy and practice. So to begin, I'm going to begin first by talking about my directed studies process. But before I do that, I need to clarify two pieces of terminology that I might be using throughout the presentation, just so that everyone's on the same page with what I mean. So first is this idea of young adults with life-sustaining technology. And what I really mean by this are young adults who require some sort of technology to sustain their life. Usually I'm talking about respiratory technology. So this is usually your long-term tracheostomies, or those with long-term either invasive or non-invasive ventilation. And this could be any mode of ventilation on the invasive side. And on the non-invasive side, I really am more focused on this notion of BiPAP as opposed to CPAP. So usually those who require non-invasive CPAP require that for obstructive sleep apnea, which is not really what I'm focused on. So I'm looking at really the long-term use of this technology. The other thing I really want to clarify is this idea of transition to adulthood or healthcare transition. And this has really almost become sort of a buzzword, particularly in pediatrics in North America. And so I really want to be very clear as to what I mean by this. And in the US-based literature, that word healthcare transition is very, very prominent, but it's used in a very pediatric-centric way. In particular, it either focuses on this discrete event of moving from pediatric services to adult services, or it focuses on a little bit more broadly on this developmental process of building self-management skills and all of those things that are required to be successful in adult care. My interest, though, is a little bit broader, and I'm interested in the conceptualization of healthcare transition that really moves beyond that pediatric-centric focus. So I view the transition process is all of those pieces of preparing for adulthood, of experiencing that transfer of care, but also, more importantly, the idea that transition doesn't stop just because people leave pediatrics, and that there is a portion of the transition process that occurs after transfer of care. So I'm thinking about this very broadly. So I always like to kind of start this with the idea of we always come from somewhere. We never come from nowhere. So I'm going to start by talking about what brought me to where I am. And like the reasons that many of us pursue further education, it comes from challenges or distress that we're finding in our practice. So I've actually been working with children and youth with disabilities since I was 13 years old. So this is something that I've really been engaged with for quite some time. And no matter what setting I've been in, whether it's been in the home, in the community, developmental pediatrics, outpatient, adult acute care, pediatric acute care, no matter where I've been, I've consistently come across young people, adolescents, young adults, and their families who in some way or another have had significant challenges around this time of transition. And it was very distressing for me because I felt like there has to be something more that we can do. I also have come across a few families that have done really well. And initially that surprised me, and then it started me asking these questions about what is going to actually support this transition and what doesn't and why. So that's what really brought me back into graduate studies in the first place, which led to my master's project. So I completed my master's a couple of years ago through UVic, and what I essentially did there was an integrative literature review. And I asked this very broad question, sort of the idea of what do we know and how can what we know inform how we support young people with complex needs like life-sustaining technology when they transition to adulthood. And what I actually found coming out of that was that the theoretical conceptualizations that we did have were not adequate for what I was trying to capture. So I ended up taking two different perspectives. I took Melius's work on transition, Browne-Brenner's work on human development, along with the findings of my integrative review, which focused on complex medical complexity or complex populations, to develop a theoretical, what I called an integrated theoretical perspective that helped me try to make sense of how do we support transition for complex population? What does this transition process look like? But still through all this, I felt like something was really missing. I wasn't really sure what at the time. I was really focused very heavily on the individual level and the provider level, but I felt like we've been doing this for a long time and nothing's changing. So that's what really forced where I shifted to thinking about, well, maybe critical theoretical perspectives is a way for me to start thinking about this a little bit differently. So I'm going to shift now and talk quickly about my process of developing course objectives for directed studies. This is sort of my way of illustrating when you want to explore something like critical theoretical perspectives, how the heck do you even start? That was sort of the question that I kept coming back to. I mean, we touched on it a little bit in some of our doctoral coursework, but so I had to really think about how do I actually want to structure how I approach this. So, and my interest in particular was around how does this inform research, and particularly within healthcare transition and in my own dissertation. So in developing my objectives, I found it very useful. I actually ended up sort of drawing on Bloom's taxonomy a little bit, and starting very broad, starting with that notion of just trying to understand and be able to understand the information that's out there, and then moving towards the analysis piece and evaluation and eventually that creation, or that upper level of Bloom's taxonomy. So I really started with this idea of what critical theoretical perspectives are, who are some critical theorists who are more prominent, what does this bring to my thinking, and how has this been used in areas of research similar to my own. With the end goal really being that I can articulate what these theoretical perspectives can bring to my own dissertation research. So I structured my course, so from that I sort of developed a structure for my course, and my readings really kind of reflected that same process of starting broad and getting more specific. So I started more with broad overviews of critical theoretical perspectives. I chose 4 critical theorists to look at. So I looked at Adorno, I looked at Habermas, I looked at Bourdieu, and I looked at Judith Butler. And I also chose some approaches to critical theoretical perspectives. They're a little more broad. So critical disability studies and then critical discourse analysis and intersectionality were those pieces. It was also, just in some discussions with Helen, it also came up that to try to do something beyond just reading. And so we developed this kind of idea of field work, where I would sit down one-on-one with faculty who use critical theoretical perspectives in their work and start to really have a dialogue about how they came to using critical theoretical perspectives, what do they feel like it brings to their work. And what that's really revealed for me is a lot more about the process of actually integrating critical perspectives and not just what we see in research articles as more of the outcome.
The process. So I was focusing on policy and substances.
Can I get you to stay close to the mic, please?
Yes, thank you. I like to also indicate from where. So I started off with post-secondary school and sociology, just broad understanding, starting to learn what structural processes, what they mean and how they actually affect individual people. So that actually shifted my lens from the individualism / individualistic kind of sense of, I guess, whether it's social structure or health outcomes or whatever that issue was, into more of a structural lens. And from there I kind of gain more interest in terms of health outcomes specifically because I was learning more about the kind of the sociological process of health. And in order to combine the two, I went into the RPN program, which was actually at Douglas. So this actually helped me, let's see here. So yeah, this kind of helped me increase my understanding and decrease the mystification of substance use and mental health issues. However, within that process of being in that RPN program, I kind of felt a bit of distress and discomfort, not only because the current system in which we work in, unfortunately, is ableist, but at the same time, with these ableist policies, people's rights are generally taken away, whether it's through the Mental Health Act. So yeah, even within that process, I found it quite difficult. So then I even went through into a direct practice, and this did not go away, of course. So yeah, experiencing more distress as well, and within both acute psychiatry and community mental health. And this was actually in trying to voice my concerns in terms of the kind of the ethical distress and the moral distress I was experiencing in providing care and treatment in the current model. I was finding that I was labeled as like a dissident and, you know, slap on the wrist, don't do that, you know, even in pointing out like just like simple ways of how to incorporate harm reduction more so in mental health practice. That was seen as enabling, etc. So it was with great, I guess, hope that I decided to like jump into the MSN program to hope to allow for more dialogue and engagement with these critical perspectives because I felt that a lot of the doors were just shutting on me. So, and luckily that's happening. So great. So yeah, Sue, I'm going to put some questions out there and no pressure to answer. I was going to see if anybody can define what health policy is or even examples of it. It's kind of this amorphous idea of like, what is policy? Okay, I'll try the next one after. So, broadly speaking, health policy refers to a plan of action undertaken to implement specific rules and expectations in order to achieve a specific health outcome and or outcomes. Health policy is a tool used to create consensus, outline future direction, expected roles, and is used to inform people. So again, very broad definition. And can we get a general answer as to who might create health policy? A chance.
Usually government.
Yep. Anybody else? Who might impact policy?
Organizations create policies to their interpretation of legislation or whatever. If we have not correctly intended legislation.
Definitely. Yep. So health authorities, similar to organizations. And I also have here the Ministry of Health. The Ministry of Health actually puts forward policies as well. And for the last one, who does policy affect? Very general and broad question. Yay! Yes, exactly. So health policy has the power to influence the health status of various populations and the organization of healthcare altogether. So the thing is, even though it affects everybody, as we will see, health policy has the ability to both positively and negatively impact certain populations. So we'll look into that. So similar to Elizabeth, we actually had relatively similar course objectives. However, I was more specific in relation to policy rather than nursing research, and generally interested in about how these inequities actually kind of shape people's experiences of health and health outcomes, specifically to mental health and substance use issues. So I went about deciding to work with Helen and Elizabeth, because Elizabeth actually has a background in critical theoretical perspectives, and being a master's student is like, oh, what better way to learn more than somebody who's actually gone through the process already. So, yeah, next slide, great. So course structure. So I went about figuring out the content of this course by doing a broad literature review, seeing what was out there in terms of current policies and practices with mental health and substance use issues. So then after that broad literature review, I honed in on specifically looking at content, and with the help of Elizabeth and Helen, I was able to hone in on which specific aspect of policy. So looking at underlying discourse analysis and as well as influence. So where is this influence coming from, and why is policy being shaped in the way that it is in the current context? So looking at that, and from being able to understand the content, I went into the readings and specified the readings through a more specific literature review, looking at more Canadian context policies. And then from there went into mapping this process. So looking at underlying values and context driving current policy, looking at critical theoretical perspectives, issues that are related to current context via these critical theoretical perspectives, and then future direction and influence of evolving policy. So yeah. Right, so we're going to introduce the critical theoretical perspectives piece. So we're just going to have a broad definition here. So critical theoretical perspectives involve social theories and theoretical approaches oriented towards critiquing society and social structures in hopes of creating a more equitable society overall. So again, a very broad definition to help encapsulate both of our areas. Can anyone share potentially what these perspectives draw attention to? So what do critical theoretical perspectives draw generally attention to? Those common themes. Inequities. Yep. Definitely.
Oppression.
Yes. Anything else that comes up for people? Okay. So we actually did like an independent analysis in terms of our understanding of critical theoretical perspectives, and then we actually came together and came up with this list of four simple points. So the critical theoretical perspectives that we found draw attention to were power relations, as noted. And this indicates how and why some groups dominate and or receive privilege in comparison to other groups. And critical theoretical perspectives actually help highlight, address, and challenge these areas of privilege as well as domination. And the other point was structural influences. So inequities and structural constraints, how these are formed, how they come to be, and also relations between subjective experiences and personal choice in relation to structural systemic influences.
All right, so the second two I'm going to speak to very briefly. One part that just kept coming up over and over again for me was this sort of notion of historical context, and I feel critical theoretical perspectives really draw my attention to this aspect, and this idea that the present cannot be understood separately from the historical context. So this really reveals how people's lives both shape and are shaped by different values, whether these be political, cultural, economic, gender, or any other values, and specifically how these are shaped over time. So this, for me, shifts attention in a very particular way. So for example, consider the statistic that Aboriginal peoples are significantly overrepresented in the prison population in Canada. Through a maybe non-critical lens, for lack of a better word, this is sort of just a statistic representing what's this current problem in our prison system and society. However, taking a critical lens for me really shifts attention to the impact, for example, of colonialism over time as shaping the circumstances that have contributed to this overrepresentation. And then finally, critical theoretical perspectives for us really draw attention to assumptions, norms, and discourses that are often hidden or taken for granted. So how we speak, how we use language, how we take up particular ideas, both as individuals and as a society over time, can lead to certain ideas becoming normalized in a way that's very taken for granted, and they sort of become hidden to our everyday consciousness. So for me, critical theoretical perspectives shift our focus to helping unearth some of these assumptions, norms, and discourses that are taken for granted. An example of this might be the prevailing notions of what it means to be able-bodied or able-minded, and how these notions shape, whether consciously or unconsciously, how we practice, what interventions we choose, and outcomes we choose for our clients and our families. So now we're going to shift for a moment, and does anyone have any thoughts about, now that we've kind of talked about what this draws attention to, is there anything you can think of that critical perspectives might draw attention sort of away from, or you might find using these perspectives you wouldn't focus on as much? Any thoughts?
The individual's experience.
Yeah. Yeah, their individual experiences and the meanings they place on those experiences, for sure. Any other thoughts? Yeah, so these this was really the big piece for us. Is like Christine said, for us it doesn't completely shift attention away from this, but it's these critical theoretical perspectives are a lot more favor the idea of collectives or shared social realities a lot more than it does particulars. Those multiple subjective meanings and identities and the diversity of those meanings. All right, so we're now going to shift into application, how we're going to apply this in our own areas. So we're going to start with my focus on healthcare transition research for young adults with life-sustaining technology. So up until this point, I've really been focusing on what can critical theoretical perspectives do in terms of my research? How is this going to inform my research questions or the topic I might focus on, and then also how this will inform methods. So in terms of topic, these are just some of the ideas that I've sort of come up with very broadly of how this might shift my focus in terms of the questions I ask. In terms of methods, it also starting to really shift my thinking about how critical theoretical perspectives will inform my choice of data collection methods and inclusion criteria, and what these privilege and how these position young adults with life-sustaining technology in particular ways. For example, an example could be interviews and the ability to speak, and how some of these young adults may not necessarily have the same ability to speak that others do, and how do my data collection methods shape that. The other question that I'm still asking myself is, what methods can I use to actually access these contextual influences and these taken for granted assumptions? You can't just go into an interview and ask people to tell you this information. I don't think it's that simple. So I've started thinking about how we could use participant observation and photo voice and some other methods in conjunction with interviews to begin to start to surface some of those things. So I need to get out of this. I'm going to show a video for a moment. We're going to do a little quick interactive activity here. So I'm going to show a brief segment of this video, and then we're going to talk about it.
William has centronuclear myopathy. It's a form of myotubular myopathy. It's profound muscle weakness over his entire body, inability to, he can't swallow, he can't breathe on his own. He could breathe little shallow breaths, but he couldn't take a big enough breath to fill all of his lungs. I looked at the twinkle in his eyes and knew that there was somebody there, and that's what I went with. When people meet William, I want them to be able to see past what they see, listen to what he is saying, and see the person that he really is, not everybody's perspectives. I don't think we have enough time. William is a genius. He loves cooking, and he's seen so many cooking shows. He's an incredible artist. He used to be able to paint and draw and color. He's helped people make knitting projects and hats and combining colors and textures. He's got a definite knack for it. I have a lot of concerns now that William is 21, going into the adult world. When he turned 18, there was a lot of transition, but all of a sudden, when he turns 21, it's like he's supposed to have some recovery or something. They want everybody to have a job that fits into one of their boxes. And coming up in the next couple of years, there's a lot of mandates that are going to happen that are attached to funding, and they're going to try to say that William has to have a job and do so many hours a month to be able to get services. There are not as many supports and services after age 18 that there were that, that we built up for infants and kids. So the adult world is not really ready for these profoundly medically fragile kids.
All right. So the question I'm going to pose to you before I talk about my perspectives on this video is, I'd like to know from you, just watching this video, what stood out for you? What were you drawn to? And at the end, what I will do is talk a little bit about, from a critical perspective, what my eyes are drawn to and my ears are drawn to in this video. But I want to start with what you were drawn to in this video and what stood out for you. And those of you who are online as well, you're welcome to type a couple sentences into the chat box and share as well.
I think what's being valued. So when we care for pediatric patients, it sounds like, and I don't know a lot about it, sounds like it's more in depth, or there's more coverage there. And as soon as we move into adulthood, it obviously becomes more difficult. So I'm seeing values, different values there.
She said that she wanted people to hear his voice, but the whole video is her speaking. I kept waiting for his turn.
And that's an excellent point. And I didn't show that part of the video a little bit deliberately. At the very end of this video, this is about a 10-minute video, and at the end, if we have time, I will show you the part where he does speak. But that's a really good point. Anything else that really stood out? How many of you have experience with this population, or have kind of seen this population from, Christine, but probably, so some of you, but not many of you. Was this what you expected? Or did you have any expectations that were similar or not to what was portrayed here?
My comment was not so much answering this particular question, but the previous one, and I would draw the attention to is that I felt a strong worry in the story that, or the answer, or the points that the nurse made around the sort of discrepancy between what we sort of do collectively in a pediatric context versus the adult care context.
Yeah, for sure.
I have an online comment to read too. Emily writes, I think historically children did not survive as long as medicine allows them to now, which informs the lack of support in transition. Yeah, absolutely. And
I thought it was interesting that she was commenting on society's value being placed on people who can work and have jobs, and how our money is connected to that. It's often when we spend money for what we have.
absolutely.
I was amazed by his artistic talent, and I wonder how was that discovered randomly, and how can we work more to dig his values on that instead of just focusing on his weakness.
Wonderful. So pretty much everything that all of you surfaced in one way or another actually do connect to critical theoretical perspectives and taking a critical lens to looking at this video. So I'm going to share briefly some of my comments. And the big piece, one of the biggest pieces here for me was that my focus, I worked with this client for 2.5 years. Just disclaimer, I do have permissions. This is a publicly available video. And Teresa, who was speaking there, is William's mom. And what this really drew my attention to when I thought about critical theoretical perspectives was the idea of these hidden assumptions and taking for granted social norms that we have in society. So some of you brought up the idea of when Teresa said that she wanted people to see past what they see, to listen to what he is saying, and to see the person he really is, not everybody's perspectives. For me, what that begins to surface some of these dominant discourses around disability and technology and disability as deficit. And some of the assumptions that people make when they see someone with a trach, with a ventilator, who's in a wheelchair, who can't move. So I think that a critical lens really would bring attention to something like that. The other quote, which some of you mentioned, is her quote that they want everybody to have a job that fits into one of their boxes. they're going to try to say that William has to have a job and work so many hours a month in order to get services. And like some of you said, what Teresa I think is really alluding to here are those discourses and policies that particularly prevalent in the United States, and this is where they live in the United States, around independent living, vocational rehabilitation, and the normative expectations of adulthood. So a critical theoretical perspective would really, that's for me what these draw attention to in this video. The other part I wanted to speak about, that goes back to my points about methods earlier, is the idea of the use of visual media in data collection and knowledge translation. And I think for me, critical theoretical perspectives draw my attention a lot more to both the promises and pitfalls of doing this. And in one sense, visual media like this, and as you alluded to, can open up our minds and our hearts to alternative ways of being and thinking and doing in the world, and ways of thinking about marginalized groups that go beyond some of those binaries, like the normal disabled binary. So William's art is a very, very great example of that. And it's as sort of a way of highlighting a strength of William's when kind of normative discourses are more focused on deficit. And I don't know if any of you actually noticed, but there were times throughout that video where Teresa was helping William pet his cat. And even things like that, by highlighting some of those things, while in some ways can be viewed as deficit, can also be viewed as alternative ways of doing in the world. Just because he can't move, it doesn't mean he cannot pet his cat. And very briefly, I wanted to touch on how my perspective has shifted from going back to my master's and moving forward to now. So this is, and I apologize for the small nature of the writing, and I'm just using this to highlight a particular part. This is the theoretical perspective that I articulated at the end of my master's program, and that was published a couple years ago. And what I really want to focus on here is how I articulated time earlier on versus how I'm thinking about it now. So in this perspective, one of the biggest highlights of this perspective when I first articulated it was that it really went beyond what theories that have typically been applied to the transition to adulthood do and think about. Time has really not been a concept that has been brought forward into the forefront of transition research and practice at this. It's starting to in practice, but really not very much in research. So what I really wanted to do with this was to emphasize this notion of transition is a process over time that does not stop when you move into adult care. So what critical perspectives have done is really help me think about time a little bit more broadly, and not just about how contexts change over time, but how those changing contexts actually impact how young people are able to achieve outcomes and live their lives in adult care. Now I'm going to zoom into that adult context for a minute, because this is the other part for me. Critical theoretical perspectives have shifted how I focus my work. So in my master's, the recommendations that came out of this theoretical paper, as well as out of my integrative review, were very heavily focused here, and were very heavily focused here. And there was a little bit of discussion of societal ideologies and social norms and culture, and those were included in this theoretical perspective, partially because the theories by Browne's work already does include it, but also it was touched on very briefly in a few of the studies that I included in my review. However, what critical perspectives now do for me is start to shift that macro system and exosystem levels to the forefront, and more so highlight how macro system actually shapes all of these other components. And that's something that I am still sort of grappling with, is how do I take what I've done here and shift it to be more critical in nature, and what would that do and what would that mean?
Okay, so now we shift on to Marina. Right, Mike. I'm not used to mics. So we're going to apply the critical theoretical perspectives that I've kind of used to inform my literature review into the policy analysis piece. Just a forenote, this is still the beginnings of the course, so I'm still kind of building the mapping process. But so far what I have found in reading whether it's critical analysis of policies or policies themselves, is different groupings of areas, which actually worked out quite well. So what I was able to do is actually group common themes. So for example, it might be this small in that, I'm not sure, but the top one indicates individualism, choice, and risk within one area, which is quite common throughout all the policies. Another section is biomedicalism, reductionism, and one that I constantly kind of joke up on is pathologization. And then the last one, neoliberalism, corporatization, and commodification. So through the use of these critical theoretical perspectives, not only was I able to actually see how these individually influence policies, whether they're underlying dialogue or actually quite prominent features, but also how they actually interrelate and affect one another, kind of building the bigger picture. Critical theoretical perspectives, furthermore, as Elizabeth noted, build on a social and structural context. Commonly, which was used as a critique, were how the need for the social determinants of health application or the sexual violence application concept, as well as this area included oppression, discrimination, ageism, sexism, homophobia, ableism, and racism. So yeah, that's kind of like what I came up with so far. Again, ever changing, but so far what I've been finding is common themes. Next one. So we will look at although it's a piece of legislature and policy quite interchangeably affect each other. So we're going to look at British Columbia's Mental Health Act. Has anybody worked with the Mental Health Act, direct or indirect practice? Sure, of course, yeah. Awesome. Okay, great. So there's some familiarity. Okay, so in looking at this, I was finding while policy and legislation are generally implemented to help reduce whether it's behavioral risk or health risks, as well as promoting standardization, access to programs, treatments, and services, they also consciously or mostly unconsciously create disadvantage, exclusion, and negative health outcomes by maintaining or reinforcing dominant ideologies that are in fact harmful. So as per the previous slide, looking at concepts like neoliberalism, biomedicalization, and so on, whether very prominent or underlying ideologies, voiced or not. And it's still quite prominent in Canadian health policy and substance policy. So building on the knowledge that I gained from Helen in Nursing 502, the Ethics and Politics of Nursing, I actually looked into the Mental Health Act, as noted. And this, so the primary purpose of the Mental Health Act is to ensure protection and care of individuals experiencing acute mental health issues through involuntary admission and treatment. So while this is the case, upon examining the Mental Health Act through critical theoretical perspectives, it becomes clear that certification process for involuntary treatment requires no obligation for informed consent, obtained consent, and nor does it actually assess the individual's capacity to consent to the involuntary process. In fact, British Columbia's Mental Health Act has not been altered since 1997, so we're about 20 years behind. And apparently it's actually about to go through the Supreme Court through a challenge in the next, I believe, 2 years, and to catch up to the rest of Canada, because British Columbia actually is indicated as being the most archaic form of Mental Health Act. So in so doing, catch up here, so through involuntary treatment, the Mental Health Act actually deems individuals with acute mental health issues as incapable of self-determination, not able to make their own choices, and illogical, and also fails to recognize personal autonomy. So pretty much the decision-making power is completely in the physician's hands through the Form 4, also known as the PINC. And there are 4 criteria, which I won't go in depth with right now, but again, it's been defined as extremely gray and very easy to unfortunately manipulate and use to the advantage of the physician. And also within the current Mental Health Act, there is no substitute decision maker. Like there is no need to follow that, whereas throughout Canada, they actually have laws implementing the indication to follow through with substitute decision makers when possible. So in disregarding the personal liberty, and kind of, which is actually in part due to the underlying assumptions that perceive individuals with mental health issues as incompetent, irrational, or lacking the capacity to make informed decisions. So these harmful stereotypes actually further legitimize this process of involuntary treatment and not needing to seek consent for involuntary treatment measures. Sorry, trying to catch up with myself here. So in other words, this is actually a form of ableism and assuming people with acute mental health issues are completely incapable of making their own decisions even for that matter, not even allowing the substitute decision maker, which takes away all power from the individual. So in justifying involuntary treatment through ableism and remaining focused on individual presentations and diagnoses, the political, cultural, social, economic circumstances which actually might be influencing and reinforcing people's mental health issues are usually generally disregarded. And unfortunately, in justifying through ableism and also using that individualistic kind of lens, healthcare providers, in being taught this manner, we actually take it on and implement it into practice. So we don't actually try to challenge, again, that political, cultural, social, and economic circumstances that actually affect the individual. Rather, it's, again, the more biomedical lens of how can we treat this with an antipsychotic medication, and for how long, and when can we, let them go in this sense. So very, very, very interesting what psychiatry is. Let's see. So as noted, it's quite integral to address rather than just a broad social and structural marginalization, including how they may impact the removal of basic human rights, such as autonomy and choice.
Yeah, right. So we're going to end with where to from here. So this is still, for both of us, a very ongoing process. We're still both about halfway through or less our directed studies. And so for me, moving forward, I'm going to be continuing to work towards this further articulation of what critical perspectives can bring to knowledge development in this field of healthcare transition related to my population, and really looking at how this can shape my methods of data collection and analysis, as well as knowledge translation. But for me, without a critical lens, I've really learned that for my research, there's a real risk of reproducing some of those dominant discourses and limiting structural influences that we've talked about today that shape the experiences and outcomes of young adults, such as those with life-sustaining technology, throughout the transition process. And on the flip side, I think critical theoretical perspectives will allow me to also take a focus on those positive structural influences and facilitators and alternate ways of being and doing in the world that may actually push back against some of those dominant discourses.
And unfortunately, I totally forgot. I want to ask if anybody had questions. We're going to talk back after that piece. Anyone have? Okay, just checking. One part that I found that was surprising is that 20-year lag. It just kind of speaks to the sense of, I think, ableism in relation to policy formulation and evaluation, because where's that reevaluation? In terms of moving forward for policy analysis piece, again, quite green in the policy area, so still figuring it out. However, for me, critical and theoretical perspectives allow me to see the prevailing patterns of power and forms of oppression that are enacted both individually and structurally to be challenged as well as altered. So for me, these are like central, or I think it's a bedrock of advocacy and able to actually help create health equity, or move towards it at least. And also a critical lens with policy analysis consists in identifying and addressing current and ever-increasing gaps in the social and health status of various groups in Canada. Unfortunately, I can't remember the origination of this quote, but the content was related to how social justice is never complete, equity is never reached, right? It's about that constant process and reevaluation, because rights are not just given to us. There always is kind of like this battle of like clawback and then kind of trying to give it back, and depending what's happening globally, and so it's a very complex process, and we constantly keep looking at it. So, yeah.
All right. So we're going to open up the floor to questions and discussions at this point. What I'm going to do is, Marina and I compiled a couple kind of more general resources that we have found have been very helpful to us in just beginning to explore critical theoretical perspectives. So throughout the question period, I'm going to leave these up on the screen. If anyone wants to copy them down or ask questions about them, I'm just going to leave them there, and we'll open the floor up for discussion and questions. So for example, some of you had said you were interested in critical perspectives in your work. After this presentation today, is there anything that's come up for you within your own work? Thinking about Courtney or Christine or Alicia or some of us who are, or Jill, who is in our master's and doctoral programs. Is there anything that's come up for you that has made you think a little bit differently within your work?
how would you not lose sight of the particulars while focusing on the collective?
I guess I could start. For me, honestly, I still get lost in that all the time, to the point where, for myself, I feel like even my identity, like, oh, that doesn't matter, it's all structural, you know, like totally surpassing that individual piece, but in the end, that's actually quite important, and I'm still kind of learning how to integrate it further. Because on my front line basis, definitely engaging with that. But when I theorize, like, I feel like it's something from that, so I'm still trying to figure it out. So maybe you have
I am still grappling with that issue myself as well. It's that kind of overarching issue of structure and agency, and kind of how do you balance those two things. I think for me, where my thinking is sort of at right now is critical theoretical perspectives are one way of looking at the world. It's not the only way. And I remember reading something, and I can't remember where I read it. It might have been Lincoln and Guba when they were talking about this. The idea that you cannot hope to understand the structural influences and contextual influences and power dynamics if you do not first understand people's experiences. So for me, I don't think that the way that I'll likely end up using this is I will use a critical theoretical perspective to access one particular piece where I want to access these contextual influences. However, I also recognize that for my population in particular, it's a very under-researched population. This population, I don't think there have been any studies with this population in Western Canada to date. So I recognize that some of my research questions may be more oriented to critical theoretical perspectives than others. And I don't think that that's something that, and so it's almost like this idea of mixed methods. And you'll have some questions that may be more geared towards critical perspectives, but others that may be answered better using a constructivist lens. And the key moving forward for me is going to be thinking about, you have these two perspectives, now how do you integrate them? And that's still a big question mark for me.
I think in addition to that point, I was also thinking how allowing groups to speak for themselves depending on a specific group, and for whether it's researchers, scholars, whatever it is, not to speak on behalf of, very important. But one thing that we can help is elucidate the continuum of experiences. So you can have, for example, what volunteer research is so awesome, is again elucidate the continuum of experiences within a certain group. So, Randy?
So you said a really interesting thing there, Elizabeth, that I'd like to push you a little bit on it. You said something about not really being able to look at things just from a critical theoretical perspective without starting from people's experience. I think that's an interesting way of trying to think about the particular versus the more structural and systematic issues that are out there. But I would challenge you to think about what's the interface between those things. Because if you just go and get a sense of what people's experiences are, and then you try and apply a critical theoretical perspective to it, you're not really understanding how people try to be agentic in the context of the kinds of structures they encounter, and how they actually make meaning of those structures.
Yeah. And yeah, that definitely, and that's a question I'm still sort of grappling with and trying to answer in that interface, and that's where I'm starting to think about particular methods that I could be using to link those two pieces. So, for example, using participant observation in conjunction with interviews is something I'm thinking about in ways of being able to access some of those structural influences while talking through with young people and their families, and I think that in that way you can start to, you're grounding it within their thoughts and perspectives and experiences, but through observation sometimes you can see things that others, that young people, people you're interviewing cannot necessarily see for themselves. And I feel like through a dialogic process that might be something that's possible. But I'm still working my way through that question, and that's something that moving forward I will absolutely have to answer. Ricky?
Thanks for raising a lot of questions for us. What I'm intrigued by is what you both framed is sort of the contrast between the individual experience and then the larger social structures. But then I mean, that's not unique to what I'm asking, but that's in the literature too. Is it sort of worthwhile to also look at the sort of processes in between? And some argue around, no, we must not only think about big institutions versus individuals, but also about sort of in between institutions, like schools or grocery stores or whatever. But then I would think if some of the mental health or pediatric services, are these also in between the institution where then actually it's not an either or but rather a continuous negotiation somehow.
You know, I absolutely agree. I think that, for example, with mental health, whole concept of harm reduction is actually still might be implemented. Even in the downstream side, for example, South Dakota mental health team doesn't have harm reduction supplies. That's just one example of how, for example, harm reduction is not being implemented. So it's about integrating it on that continuum. So if you walk into a clinic, what are the basic things that we should be presenting with? So it's on an individual clinic level, but also on that policy level, harm reduction. Like, how is this not being implemented in every clinic? Is this not the standard? Is this not evidence-based treatment that we have? If so, why not? How is this coming down to individual towards the clinic? So,
and I think to CRiHHI, your example of the school got me thinking back to, and some of you brought this up in relation to the video of William, is this idea of conditions being typically these young people would not have survived that long. And so thinking about how over time these conditions have been kind of conceptualized from kind of across levels all the way up to the policy level as, for example, myotubular myopathy is a pediatric condition. And for those of you who are online, I'm doing air quotes around this. And we think about this as a pediatric condition and how some of those discourses that are more structural in nature, it makes me think about how those have now trickled down through into, for example, universities and health professional education, and how at those levels we can either push back against that or we can continue to reproduce some of those ideologies of these conditions as being pediatric conditions. Something I hear continuously from my colleagues in the U.S. Is the young people with congenital heart disease. Adult cardiac surgeons do not want to touch them. And they say, congenital heart disease is a pediatric condition. I'm an adult cardiac surgeon. I do not treat this. So I think, I don't know if CRiHHI, if that's kind of the thing you were trying to get at with, it's looking at the in-between and not just how this idea of pediatric condition shapes the care that young adults get, or their experiences, or their healthcare access in adult care, but looking through kind of how that actually moves back and forth in between.
Yeah, and I think in comment on what you say, that it seems a little bit more hopeful that you're not sort of falling into despair of what, you cannot change larger social structures. Because what you said just in your answer is like, when you're sort of thinking in sort of in between context of services, then you cannot either push back on them or reproduce them. But even in that language, it seems that suddenly that the person working in these systems or making use of these systems has a little bit more of an active role and can either, do something constructive or be completely, repeating the system or something. So there seems to be more opportunities for action.
Yeah. So I think, last point. In terms of when you brought up the education system, I did want to bring up the concept of that that's extremely important. In fact, discrimination is socialized in all of us. And through critical vertical perspective, we can actually become reflexive of these processes. And to actually engage on that, I guess that even like elementary level of like unlearning these historical and quite harmful processes that we've taken on and continue to kind of reinforce is extremely important. How that's done, I wish I had the answer, but I think that's quite central, is getting into the education system for sure. Yeah.
Well, I think we need to let everybody know. Yes. Thank you for coming. Thank you for